Surgery has a very small role in the treatment of small cell lung cancer. For patients with a true stage 1 small cell lung cancer, surgery can be considered and is incorporated in our current guidelines. This is based primarily on retrospective data, where patients with a stage 1 small cell lung cancer who underwent surgical resection did have a very good prognosis. It's important to remember stage 1 small cell lung cancer is exceedingly rare, and most patients who are thought to have small cell lung cancer, stage 1 disease, end up being upstaged at the time of surgery with occult lymph node involvement or metastases detected shortly after surgery. It's important that when stage 1 small cell lung cancer is considered, that staging really is exhaustive. Biopsies of mediastinal lymph nodes, a PET scan and MRI with and without contrast, if there are certain cytopenias, even a bone marrow biopsy. Really an exhaustive staging workup is necessary because stage 1 small cell lung cancer is truly quite rare. And if nodal involvement is identified, those patients aren't really going to benefit from surgery, and all we're doing is really delaying the therapy that they need. If a stage 1 small cell lung cancer truly is identified, where lymph nodes are biopsied and benign, no distant metastases are identified, surgery can be considered, in part because at times those will not be small cell lung cancers. They will be other neuroendocrine tumors, carcinoid, atypical carcinoid, which on a fine needle aspirate may resemble a small cell lung cancer. And if it is a different type of neuroendocrine tumor, then surgery is quite appropriate. So it can be considered, but very unlikely, and primarily small cell lung cancer is not a surgical disease.
Yeah, I think what we need to remember about small cell lung cancer is roughly 30 to 40% of patients, 30% of patients have limited stage disease where the goal is really cure. So this is a very different approach than extensive stage small cell lung cancer, where we're just giving chemotherapy. For limited stage, we're really looking at concurrent chemoradiation, chemotherapy with radiation, most commonly with platinum etoposide with radiation. And there's been some data in the past 5 years to look at optimal dosing of radiation with chemotherapy. And the Convert trial was a trial looking at single dose radiation radiation dose daily versus BID radiation concurrently with chemotherapy. And this was a superiority trial trying to prove that daily radiation was superior to twice a day radiation. And that trial failed to meet its endpoint. And because of that, I think we still consider BID radiation dosing to be the standard of care concurrently with chemotherapy. And that's what we try to do at our own institution, is concurrent chemoradiation with platinum etoposide with BID dosing of radiation for limited stage small cell.
Prophylactic cranial irradiation does seem to have a role in the treatment of small cell lung cancer, but its role is currently evolving. For limited stage small cell lung cancer, we know through our collective experience that the brain is a reservoir site, that patients unfortunately often relapse in the brain. Based on that natural history and the tropism for CNS spread, low-dose radiation to the brain, or prophylactic cranial irradiation, PCI, was explored in patients with small cell lung cancer. Initially limited stage with a complete response, later limited stage with any response, and extensive stage small cell lung cancer. Both seem to derive benefit from prophylactic cranial irradiation. These are quite old studies, but in those studies, patients who received PCI versus those just observed did seem to derive a benefit in the form of a decreased risk in the development of brain metastases and an improvement in overall survival. The flaws with many of those early trials is that MRI screening for the presence of occult brain metastases was typically not performed. This has really called into question the value of PCI. In the extensive stage setting, the phase 3 trial of PCI versus observation was replicated in a Japanese population with the use of MRI, both at screening and during the period of surveillance. This eliminates occult brain metastases from being included in the population. And with the use of MRI in the current era, PCI was still associated with a decrease in the incidence of brain metastases, but did not confer that survival benefit. So a decrease in brain metastases without an improvement in survival, and at a cost, not simply a financial cost of radiation, but really a cost in neurocognitive capabilities, really called into question the value of PCI. It is no longer necessarily incorporated in all patients with extensive stage small cell lung cancer. Does that extend to limited stage small cell lung cancer? We simply don't know. However, it certainly has called into question the role for every patient. It is worth a lengthy discussion with patients. Really, a shared decision model is necessary until we have data in the limited stage setting.
And I think we need to remember that while we're trying to cure patients with limited stage small cell with concurrent chemoradiation, unfortunately, the median survival for these patients is still only 18 to 22 months in some series. The 5-year survival rate for limited stage small cell, treated limited stage small cell, is only 10 to 12% or 10 to 15%. So unfortunately, the majority of patients do relapse, and this is an unmet need on how to best treat them. Yes, we're going for cure, but most patients, unfortunately, 75 to 80% of patients will relapse at some point, which really makes it challenging to treat these patients. And we're coming up, of course, with new therapies in this setting to improve outcomes for these patients.